Hey everyone, and welcome to The Explainer. Today we're unpacking something that affects every single one of us, every single day, often without us even realizing it. We're looking at the architecture of public health. We're going to trace this entire public health ecosystem, starting from the absolute micro level, literally down to the exact way a nurse washes their hands, all the way up to the macro level, exploring how global crises and pandemics are managed on a planetary scale. It's this massive, fascinating, interconnected web, and by the end of this, you'll see exactly how a hospital room in your hometown is directly linked to international health policy.
Okay, let's dive into this. Here is the structural funnel we're about to explore today. 1. The public health ecosystem. 2. Micro, clinical infection prevention. 3. Macro, national outbreak tracking. 4. Global, worldwide health crisis. And 5. The big picture.
Section 1. The public health ecosystem, a multi-tiered approach to safety. You know, it's really easy to watch the news and just see a bunch of disconnected guidelines, right? Like a food recall over here, a new hospital policy over there, an international travel warning somewhere else entirely. But the reality is, these aren't isolated events. They actually form a highly cohesive, multi-tiered defense system against disease. Now, to understand this shield, we have to look at its fundamental building block, infection prevention and control, or IPC for short. The core definition of IPC is a practical, evidence-based approach preventing patients and health workers from being harmed by avoidable infections. And the absolute key phrase to remember here is operating at multiple scales. Because before we can look at the whole world, we have to look at the room. And that brings us to our very first line of defense. Section 2. Microclinical infection prevention, granular standards in healthcare facilities. Now, what's really interesting about this is that national and global health security doesn't actually start in some fancy boardroom. It starts with incredibly granular, super specific local protocols right inside healthcare facilities. It's all about what happens at the bedside. The sheer volume of protocols required just to maintain a baseline of safety is honestly staggering. Take the APIC text, for example. It's basically the definitive go-to guide for infection preventionists. It is wildly compartmentalized. Chapter 27 is dedicated entirely to hand hygiene. Chapter 30 covers aseptic technique. Then you've got entire separate chapters for specialty populations. We're talking burn units, neonates, oncology. But to really grasp how rigorous these micro-level protocols are, we need to apply them to a specific high-stakes scenario. Let's look at Chapter 35, which deals with vascular access device-associated infections. Specifically, we're focusing on something called a CLA-BSI, a central line-associated bloodstream infection. Preventing a CLA-BSI relies entirely on a strict, step-by-step checklist known as a bundle. So let's break down the insertion bundle first. When a healthcare worker inserts a central line, they don't just, try to be careful. They follow this incredibly detailed 5-step insertion bundle to the letter. Step 1, rigorous hand hygiene, executing those exact standards from Chapter 27. Step 2 requires maximal sterile barrier precautions, and we're not just talking about throwing on a pair of gloves here. We mean the whole shebang: a cap, a mask, a sterile gown, sterile gloves, and a large sterile drape covering the patient. Step 3 is skin antisepsis using chlorhexidine, and it has to be applied specifically with friction to effectively kill bacteria on the skin. Step 4 is selecting the optimal insertion site. For instance, they strictly avoid the femoral vein in adults because it carries a much higher infection risk. And Step 5, which is absolutely crucial, is a daily review of whether the patient actually still needs the line. Because, well, the fastest way to prevent an infection is to just remove the device the second it's no longer medically necessary.
But hey, the vigilance doesn't stop once the line is actually in. That brings us to the maintenance bundle. Think of this as the ongoing security patrol. Step 1 is famously known in hospitals as scrubbing the hub, meaning you vigorously clean the access port with an appropriate antiseptic for at least 15 seconds before every single time the line is accessed. Step 2 relies on Chapter 30's aseptic technique for all dressing changes to make absolutely sure no contaminants sneak in. Step 3 is routine, relentless hand hygiene, and Step 4 is doing that daily assessment for catheter removal all over again. This level of detail, literally scrubbing a tiny plastic hub for exactly 15 seconds, is what we mean by the micro level of public health. This is the frontline armor.
Section 3. Macro, national outbreak tracking. When infections leave the hospital.
But what happens when an infection leaves the hospital? Or, when an illness originates out in the community, in our food supply or our consumer products? Well, that requires a completely different layer of architecture, driven by organizations like the CDC. This timeline of recent outbreak reports brilliantly illustrates their relentless pace. In just a few months, the focus shifts wildly. On October 30th, they're tracking a listeria outbreak linked to prepared pasta meals. Literally the next day, October 31st, they have to pivot to a salmonella outbreak tied to moringa leaf powder in supplements. By mid-December, the machinery shifts completely from foodborne illness to viral prevention, rolling out new individual-based decision-making guidelines for hepatitis B immunizations for infants, and then, bam, by January 14th, they are right back on the food safety beat, tracking another salmonella outbreak, this time in super green supplement powders. The surveillance is constant, it's rapid, and it covers an immense variety of threats across an entire nation.
So, we've got the 15-second hospital hub scrubs, and we've got national trackers chasing down salmonella in green powders. But here is the massive question. How do we scale these efforts for the entire globe? How does any single organization possibly manage health on a planetary scale, across borders, cultures, and vastly different economic realities?
Section 4. Global, Worldwide Health Crises, the Dual Burden of the WHO.
At this macro planetary level, the World Health Organization operates with a massive, incredibly complex mandate that essentially forces them to fight on two entirely different fronts at the exact same time. On one hand, the WHO is constantly responding to acute humanitarian emergencies. We're talking about devastating, immediate crises, managing the health fallout from 1,000 days of war in Sudan, addressing severe famine conditions in the Gaza Strip, and tracking highly infectious disease threats like avian influenza or Ebola. But simultaneously, on the other hand, they are also tasked with managing chronic, slow-moving global health trends, what they call non-communicable diseases. And this involves some really complex policy initiatives. They focus on stroke prevention, they host summits on traditional medicine, and they even evaluate how economic policies impact our health.
So the crucial point is that global health isn't just about stopping a sudden virus. It's also about analyzing systemic, long-term drivers of disease. The WHO operates from the stance that economic levers are directly tied to health outcomes. For instance, the reporting clearly indicates that lower taxes on items like alcohol and sugary drinks create cheaper prices, which they then link to a subsequent rise in non-communicable diseases, obesity, and injuries on a global scale. Whether it is a fast-moving flu or the slow-moving impact of dietary policy, the global health architecture attempts to monitor and influence the whole thing.
Section 5. The big picture, connecting the dots. Let's move to see how this builds and connects all the dots. We've gone from the micro all the way to the global. The APIC hospital guidelines ensuring sterile vascular access, the CDC's national tracking of contaminated food, and the WHO's global emergency and policy management, they all form one giant, interconnected shield. It is a massive, fragile architecture that completely relies on every single level doing its part. I want to leave you with this provocative thought to ponder. If a localized hospital protocol fails, if a micro-infection is allowed to spread, how quickly does that single failure escalate into a macro crisis requiring a global response? Understanding this ecosystem really shows us just how connected our health truly is. Thank you so much for joining me for this explainer, and keep questioning the systems that keep us safe.